Hey guys, it's Cami, the nurse practitioner with Palliative Care. I've been asked to discuss comfort care and comfort measures with you guys. So I want to first start by saying that comfort care is, I guess, a title that we're using to say that the measures that we're providing to the patient are all focused on comfort care. So typically when we transition a patient to comfort care, it really is kind of like what we would do on hospice if the patient were on hospice, but instead they're in the hospital. I do think some of the confusing factors have been that we are making adjustments to what comfort care looks like as we are seeing different outcomes with COVID-19, but also just with families over the last 2 years have spent a lot of time researching and becoming more aware of what's out there, and so we're getting a lot of different requests. So I think the one that I've seen that's the most confusing has been when I transition a patient to comfort care and leave them on a ventilator. There are a multitude of reasons that I would do that. One, obviously, is family request. I typically try not to do that unless I feel like the patient is sick enough that other things being stopped basically will help lead to allowing the patient to die somewhat naturally. For some people, I think we just have to understand that they believe that removing someone from life support is an active sense of causing a person's life to end. So if I'm afraid that the patient is fairly stable in many other aspects, and that if we stopped everything but left them on the vent, they could still survive for days and days and days, I will try to talk to the families about that. But we also have to accept that not everybody believes what we believe, and that's a pretty core belief about ventilators, and we just have to kind of work with what the families can do. Another reason that we have stopped all other things, transition to comfort care and left patients on the vent, is when the patients are so symptomatic that I have concerns of how difficult it'll be to keep them comfortable off the ventilator. So if the patient's on 2 or 3 pressors, cardiac meds and things of that nature, and we know that if we stop those things and leave that ventilator in place, it'll certainly assist in managing some of the respiratory stuff we can see, but allowing them to die naturally, but as gently as possible. The third aspect that I can think of is when we have families that have made the decision to withdraw and transition to comfort care and the patient's been on a paralytic. I cannot extubate ethically or morally, personally, for a patient that's been on a paralytic. We have paralyzed their body, including their diaphragm. So we can transition to comfort measures and we can stop everything, and I can lower the ventilator settings as long as I'm still breathing for this patient. That's the ethical way to proceed with comfort care. Now, another thing about comfort care that I think confuses a lot of people and does result in a lot of pages to myself and my partners is transitioning a patient to comfort care, putting the label on the chart that says comfort care, but keeping heart medications or blood pressure medications. And I think that in our minds, we have gotten to a place where we think comfort care just means morphine, Dilaudid, Ativan. But the reality is beta blockers can help ease air hunger. High blood pressure never felt good to anyone. So there are a lot of things that aren't considered comfort drugs that do assist in a patient's comfort. In fact, there are times where I would tell you antibiotics assist in comfort. And so I do get a lot of pages, as well as my partners, and we've talked about it very recently, about the number of pages that we've gotten where people are saying, well, I can't give this pain medication because the comfort care banner's not there. Well, the patient doesn't have to be on comfort care to get a pain medication. Yes, if they're a full code and their vital signs don't support safe dosing of an opioid, then you do need to hold it, but you need to page the palliative care group to explain why you held it. But if that comfort care banner is there, we have reviewed most of those medications and made a decision on keeping them or not keeping them. Sometimes they're our decision, and sometimes it's just a fair and reasonable negotiation with the family. I guess what I would say is, if you have any questions about it, I would much rather you find one of us, page us, and talk about it rather than just not doing something or doing something for a patient that we come in the next day and hear families ask questions about, or the patients. But you can provide pain medication and pain management for a patient that is not Comfort Care. And you're going to see Comfort Care on patients' charts that are still on the ventilator and maybe still on other medications. The other title, I guess, we're using now that I think nurses are going to have to be very aware of and stay on top of is the order to do not escalate care. Basically, do not escalate care is a plan that we make with the family that says, I want him comfortable, but I don't want to stop the things that we're currently doing. So then we have the conversation of, if he or she gets worse, would you want us to add more pressors or have more scans or procedures? And many times people will say, I just want to try this, and if it doesn't work over a couple of days, then we can address stopping everything. But until then, just do what we're doing and don't add anything. That's a do not escalate. The other time that I use a do not escalate is when I'm waiting for a grandchild to get here from another state or country, or a friend or any other relative. And the family says, let's do what we're doing. Make him comfortable. Do not escalate the care, but do not stop pressors. Do not stop the vent. And if he gets worse and he dies naturally in this state, I'm okay with that, but we would like to try to continue these things until XYZ gets here. So those are largely the differences you'll see as it relates to that end of life care planning and kind of the titles that you'll see. But again, I can't encourage you guys enough that if you have questions, just reach out to us. I've done a couple of shift change roundup or conversations with groups of nurses. I'm happy to make more of these videos if they're helpful. Just submit questions or concerns you have, or just reach out to me personally. The answering service can get me, or if not, I think 90% of you guys probably have my cell phone number. So just reach out and I'll see what I can do to help clear up any confusion. All right, guys, thank you.